Cindy and I are going to tag team this section, and I guess when it comes to the neurodevelopmental assessment, I think this is the section that is sometimes a bit overwhelming for people. It's the bit that's quite daunting. I think the good news, though, is if you are a psychologist or you're someone who's working in speech therapy and OT, a lot of the assessments that are included in this section are actually your bread and butter things. So these are things that you're probably doing standardly, but you probably haven't considered sort of linking them together and doing them as comprehensively as we do when we're looking at a FASD assessment. So a lot of it is really around just expanding, I think, looking at the various domains that perhaps you hadn't considered previously. So when it comes to the neurodevelopmental assessment, what are we looking at? Well, as Doug has already mentioned, there is 10 neurodevelopmental domains, and we're really looking to assess as many of those as we can. So practically speaking, I know one of the difficulties, particularly if you're not working in a clinic that is specialising in assessment of FASD, is that you may not be standardly, doing, 5, 6, 7 of those domains. And we'll talk about the reasons why covering as many of those domains as we can is important. Certainly if you don't have the practical ability to cover all those domains, you don't have to. But the more that we can cover, the more information we're going to get about the core deficits that the young person's experiencing. Obviously having a multidisciplinary team is a real advantage in this set of settings. Psychologists and clinical psychologists, neuropsychologists, because we're involved in so many aspects of those domains, where we're looking at maybe 6 of the 10 domains that psychologists have some involvement in, having access to a psychologist, or a neuropsychologist is incredibly important. But the other key players are often people like speech therapy and occupational therapists. But we're also getting input from other people, and I guess I include in that multidisciplinary team, even though teachers are not formally assessing, we're getting really valuable information, that indirect information from teachers, carers, other people who are working with a young person. We're going to be using, when we're doing these assessments, a variety of ways of assessing. So probably the one that we're most familiar with, or we think about most, is that direct assessment. So that's the use of a whole variety of psychometric tests. And again, this is kind of the bread and butter of psychologists. These are assessments that we're using very standardly already with young people when we're assessing them with other concerns, whether that's ADHD or specific learning disorders. We're also trying to make use of as much of the indirect observations as we can. So again, this is where being able to access information, particularly from people like teachers, school reports, guidance officers, if young people are in care, getting some of that indirect information and reporting information is really key. And that's particularly true when we have young people in care who may have been in multiple placements or might have been in multiple schools. We need to be able to access information from a variety of sources. And then, of course, many young people, and certainly the young people that I would see who I would suspect have FASD, quite often come to us with the ABC of diagnoses. So many of them are already coming with pre-existing diagnoses, and in particular things like ADHD, sometimes ASD, certainly things like oppositional defiant disorder, anxiety disorders, depression. Some may have some intellectual or cognitive functioning, specific learning disorders. So quite often, for me, that's a real red flag. If I have a young person who's coming to me and they already have some pre-existing diagnoses, number one, we want to have a look at when they were done and how they were conducted. For me, the real value in terms of doing a really comprehensive assessment is really around being able to identify where core deficits lie. And the reason why we need to understand those core deficits is because they then map onto these practical and behavioural symptoms that we see in young people. And that, of course, leads us to the most effective strategies for managing those. The other thing we want to do, of course, is not just identify deficits, we do want to know where these young people's strengths are. And again, young people with FASD have a great variety of strengths, and of course, if they're experiencing difficulties in a great many areas in their life, it's really important that they are able to recognise that they have strengths and qualities and things that they can contribute. And so we want to highlight that for parents as well as teachers, and so they can continue to develop things like self-esteem, particularly in school settings. We're trying to reinforce with people that, this fetal brain damage, the damage that's actually done can occur during any of the trimesters. And we know that can happen with or without the presence of microcephaly and with or without the presence of growth deficits. So if we sort of track the trajectory of that, so if we start with the prenatal alcohol exposure, what we know is that can result in structural brain damage, and that can happen at different levels. And again, I think this is something that's often really important for both parents and carers, but teachers, educators and other professionals to have an understanding of the different levels at which that brain injury can occur.
So when we think of FASD, this is a real spectrum, okay? So as we say, there's no particular profile. We know not every child has an intellectual disability. Certainly when we look at our numbers at the clinic at home, we have 40 to 50% of the kids coming into our service who do have an intellectual disability, and about 2/3 have a comorbid diagnosis of ADHD. We know that some children have significant motor difficulties, others it's an area of real strength. What we do know is that most children have information processing problems. So they get overwhelmed very quickly. This occurs more when there's increasing complexity. When I think of complexity, I think of external complexity, more things going on in the environment, but also more things internally going on within themselves. So if they're tired, if they're hungry, if they're emotional. So capacity changes depending on the environment. So we have these 10 domains, and we're going to talk about these 10 domains separately, but the really important thing to keep in mind is that they do overlap. For example, if we can't attend, it's really hard to remember. It's really hard to talk. If you don't have good language skills, that will affect your verbal memory. So even though we're looking at these 10 domains, we have to acknowledge the gestalt and how each domain affects one another. What we're wanting to see is significant neurodevelopmental impairment. And that's why we look at least 3 domains. So the diagnostic criteria for severe impairment is that below 2 standard deviations below the mean. So we'll again talk about what this means for different tests as we go through, but generally we're talking about a global score, for example your full scale IQ or your core language scale from the self, or we're talking about a major subdomain. Again, we have to be thinking of a neurodevelopmental approach. We're going to be talking a lot about tests. We need to triangulate that information with what we see and what we hear and the history of the child. It might be a language delay of acquiring language. It might be hyperactivity in the preschool area. It may be early difficulties around adaptive behaviour and eating and dressing and sleeping. So what we're wanting to do is look at that history. What is the pregnancy healthy? What happened? Was there an early delivery? All those things impact, and they impact into the postnatal period. When we look at motor skills, what we're looking at is significant impairment. Now, it could be across the composite, or it could be at those problem areas, spinal, gross motor, visual motor integration. Difficulties with writing. Why is that? Is it because it's a language issue, or is it because they're having difficulty with their fine motor? It feeds into some of our processing speed and the whisk, where is that processing speed because they're finding it difficult to process information, or is it because they can't coordinate their fine motor control? So we need to be understanding that, because that will dictate the strategies we give to school. Do you want to?
So the next domain is cognition, which again is probably one that people are fairly familiar with. So this is an area, I guess, that we're often looking at. So typically we're talking about IQ assessments. One of the major, I guess, misconceptions that people have around FASD is that most children with FASD will have some kind of overall intellectual disability, when in fact we know that that's not the case. In fact, probably somewhere around, depending on the setting that you're in, but probably in the general population, somewhere around 15% of people will meet criteria for a mild intellectual disability. So again, you can look at this domain, looking at it in terms of global scores, because certainly some people with FASD will meet criteria for an intellectual disability. But more often we're probably looking for deficits in one of the subdomains, and that can be verbal comprehension, visual spatial ability, fluid reasoning, processing speed and working memory. Again, you see a whole range of deficits across the spectrum, and there's no one profile of a young person with FASD in terms of which of those domains will be affected. But certainly we do see sort of some consistencies around things like processing speed, that these kids really find it difficult. They're very delayed in their problem solving, in their thinking, in their cognitions, in their schoolwork, that processing speed on so many different levels is really quite delayed. Sorry, we're just jumping between the two of us.
We find this language domain really, really important. When I looked at the data from my research, about 80% of the kids in my research had a severe language disorder. This is what gets them into trouble at school. So when we think about receptive language, our ability to understand, asking for repetition, sometimes people say to me, they've got a really poor memory because they keep asking me to repeat myself. Well, it's not memory. This is where we can start teasing it apart when we've got good assessment data. It's about not understanding what we say. Difficulty following directions, often only being able to follow one thing at a time. Literal understanding. I mean, we've got so many examples. The other day I saw a young girl and her nan said, can you take the washing out? So she did. She got the basket and she put the washing out and she put it out by the washing line, not thinking to hang it up. You know, in terms of our expressive language, difficulty communicating needs, difficulty recalling words. I have a number of kids that don't have the words, so will be, oh, you know that thing that cuts paper, you know, for scissors. They use really poor language appropriate to settings. So this comes into that application, pragmatic use of language where, you know, the way you talk to your mates shouldn't really be the way you talk to the police. And, you know, by middle childhood, most kids have kind of got that they change the kids often don't. The self and the PLS5, obviously they are often always given by our speech language therapists. We also use the TOPS. And then the test of narrative language is another really important one, and that has oral narration score in there as well, which is really helpful around that pragmatic information.
So moving into academic achievement, so this is probably a domain that, again, people are often assessing quite often in general psychological practice, and it's one of the areas that parents and caregivers report continuously about, that their children are failing to achieve in school and they're having some core deficits in the areas of reading, writing, as well as mathematics. And what that looks like in practice is that they're quite often failing in school subjects. And sometimes this isn't very evident at the younger age, because what we see is normal development, that the difference between peers with learning issues and normally developing peers is not very big. So some of these discrepancies actually don't become more apparent until they get a little bit older, until you're looking at that sort of year 4, year 5 level. But the ways in which we assess that is, the ways in which I guess we are often assessing for a specific learning disorder. And in fact, again, many of the young people that I would see in the general clinic where I work are coming in already with a diagnosis of a specific learning disorder, or they're coming in for diagnosis of a specific learning disorder. And it's only when you have a look at the other factors that you realise they're probably at risk for fetal spectrum disorders as well. And so we do see those difficulties in reading and writing and in understanding text. Again, there's a sort of a crossover there in terms of comprehension stuff, but being able to understand what it is they're reading. They often have poor literacy. But the big area that seems to get, again, anecdotally reported by parents over and over again is the area of maths. So mathematics, particularly anything beyond sort of fairly basic maths, and I guess it kind of makes sense in terms of core deficits. Again, when we have kids who are quite literal and they're often able to do the very basic maths, but as soon as maths becomes more abstract, and that includes, even things like division and multiplication, we start to see kids with FASD really start to struggle in the area of mathematics, just because of that very abstract nature of maths. So again, there's a variety of assessments that people are probably already using. Things like the Wyatt would be the most common one that's done, but we can also use things like the Woodcock-Johnson and the RAT as well. So the next major domain is looking at memory. So here we're looking for issues both with verbal memory as well as visual memory. We are looking at the broader domains of memory here. So we can be looking for differences in the composite scores that are falling below, or significant discrepancies between the different domains of memory. And what in practice, again, what this looks like is often these young people have gaps in memory. I think maybe a good example of this is you might have a young person who can't recite the alphabet. They don't have the capacity to name all the letters in the alphabet, yet they have the capacity to read. We probably move away from just using something like the WISC to moving into some more specific memory assessments, and something like the NEPSI is particularly good because it actually measures memory in a whole variety of different domains. So you can look at that verbal and visual memory, you can look at that immediate memory as well as delayed memory, and you can look at memory in a whole variety of different contexts. So memory for faces, memory for word lists, memory within the context of stories. So the next one is attention, and we're looking for impairment in two or more various aspects of this attention. So we're looking at selective attention, so the ability to focus on the right information. And again, this is something that kids with FASD often struggle with a great deal. They have a great deal of difficulty screening out the extraneous information and knowing where to put their attention. And then I think that also hooks in, to sustained attention. So that's the ability to be able to maintain the ability to stay on task without getting distracted. And again, there's other things that impact on that, and that may be things around impulse control, hyperactivity and things like that. But it also comes back to some of these core abilities in attention. When we move into divided attention and alternating attention, you can see it really steps up in terms of the demands. So we're really looking there, do they have the capacity to attend to two or more pieces of information at the same time? Again, practically, how do we see that? You would see it, teachers would describe it in the classroom, because often the demands that are put on children, again, in the classroom, even though they may feel like it's a very specific task, we're actually requiring kids to do numerous things at the same time. We're asking them, to sit at a table. We're asking them not to engage in the piece of paper in front of them. We're asking them not to engage with the child next to them. And we're also asking them to do the tasks that's on the board. And again, this is something that we know that kids with FASD really struggle with, because they find it very difficult to both be able to manage two competing bits of information, but also their ability to switch between information is quite impaired. Again, it's a higher order task when it comes to attention. Indirect assessment, again, we really want to get a whole lot of information, particularly from schools and from parents. So they are really important sources of information that sort of provide that extra triangulation based on not only what we're seeing in the assessments, but what they're also seeing in the classroom, what they're seeing at home. And parents and caregivers will be very easily able to tell you quite often about the difficulties that their children are having with attention in a whole range of different settings, and they can give you a whole range of different examples as well.
I think attention is one of those things that really trip kids up, and what happens when a child then becomes fatigued. It's almost like a computer powering down, and so I'm saying most children with fatigue, don't get me wrong, but this really obvious, just cannot do anything more after 40 minutes is really important information to be giving to schools and to parents or to other people that might be in contact. So I think attention is one of those things because it so relies on being regulated that it's trying to get information around what is their attention like. And I know in the guide it's great to see that sometimes indirect assessment is important, and sometimes even more important than what we actually see in the clinic room because of the environmental considerations. Executive functioning, when we think about ADHD, we think about attention, hyperactivity and impulsivity. The important thing for the guide, and this is in line with the Canadian guidelines as well, is that attention is in the attention domain, and hyperactivity and impulsivity, that inhibition, that impulse control, is in the executive functioning domain. If a child has a diagnosis of ADHD, hyperactivity, that then goes into executive functioning and not in attention.
Certainly in terms of the diagnosis with ADHD, we're looking at around 66%, I think, of young people with FASD also meet the criteria for ADHD.
Affect regulation. In the guide, what we're looking for is DSM diagnoses. For me, I think the big one is disruptive mood dysregulation disorder. Because what I see is rather than, and I think this probably depends on the age of people that you see, but especially in younger children, we're seeing more of that dysregulation, that up and down, rather than a pervasive depression that we're used to seeing under an Access 1 diagnosis. But the really important thing here is just making sure that if we're thinking about dysregulation, it's a long-standing problem. This is not just a short-term, response to something that's happening in the environment or something they've just moved foster carers or school, or we need some periods of stability to be able to know and to see that developmental history.
The bit I'd add in with this one is if you're seeing a young person and they're presenting with a lot of aggression, for me that is often a flag to go back and assess for anxiety, because in terms of how anxiety often presents in these younger people is they feel very overwhelmed, and as I said, they kick into fight or flight. And for a lot of young people with FASD, it's fight. And so what that comes across as is aggression and those kind of behaviours, when in fact if you dig a little deeper, quite often it actually is underlying anxiety.
So this is the last domain, which is adaptive behaviour. So obviously there's a number of assessments here. You'll use what your clinic uses. At ours, I like the Vineland, my colleague likes the ABAS. We also have, information from the pragmatics profile sometimes can come into here. This is where we have to be really careful not to double dip and give two domains as language and adaptive behaviour. It should only be one if we're talking about the same construct. Some of that TOPS information can give you information for this domain. I specifically looked at social cognition and social skills in my research, so I have used a couple of different assessments, the DANVA, which is a non-verbal facial recognition, which I found really related to school functioning, especially a child's ability to read emotions on adults' faces. The reason I chose that over the NEPSI was that the NEPSI affect recognition is more about matching rather than identification, and I wanted to tap into that. There's the theory of mind with the NEPSI. There are other theory of mind tests that you can use. So I think, as clinicians, we use what's available and what we know. But what we're trying to do, again, is look for that significant impairment. The tricky thing here is around when children get older or become adults. Sometimes you might have to use some clinical judgment, look for documented difficulties around independence, how much support do they need to be able to function, because as adults it's quite hard to get, you can imagine, to self-rate or to find someone who might be able to rate that for them.
One of the questions that comes up is, do I need to assess in all the domains, and which domain should I use? And I guess my answer to that is, assess in as many domains as you can. If you, for whatever reason, have some limitations on that, then try to select the domains that are probably going to be the most obvious, the ones that are sort of standing out, the ones that will be, identified by teachers and parents and that have a clearly identified need.